So I'd like to thank everyone for joining us today. Today's topic is obviously very timely, and I'd like to thank our speakers. Our first presenter today is Dr. Lamisha Hill. She is originally from the Chicagoland area. She obtained her doctoral degree at the University of Oregon in counseling psychology. She then went on to get a postdoctoral fellowship at the University of Berkeley in counseling and psychological services. And she then went on to get a pre-doctoral internship at the Counseling Center at UC Irvine. She currently works at University of California, San Francisco. She supports students navigating the complexities of the university system, and she's passionate about multiculturalism, diversity, allyship, and supporting underrepresented communities. We're thankful to have her today. Dr. Hill, take it away.
So welcome everyone, my name is Lamisha, I use she, her pronouns, and I, as was mentioned, serve as the Director of Multicultural Affairs at the University of California, San Francisco. So I come to you as a psychologist and really in the spirit of sharing a message around diversity, equity, and inclusion. Really my objective for us today is to have a little bit of an authentic conversation and dialogue about the current events in our sociocultural climate. And then I want to provide some diversity foundations as a framework for you to apply to your knowledge, expertise, and the upcoming knowledge that Dr. Bakare is going to bring us around reproductive sciences and male fertility. So that is not my area of expertise, so I'm going to stick to what I know best, but really just look at it as a framework and as a lens to then be able to apply it to all the other places in your work. All right, so I have nothing to disclose other than I am a licensed psychologist by trade, and since I can't see you all, perhaps I cannot analyze you. It is a really important practice that we engage in a land recognition, and I know that you all are across the country and maybe in international spaces, but where I sit right now in the Bay Area, I want to give honor and recognition to the ancestral homeland of the Ramaytush and Ohlone people, who are the original caretakers of the San Francisco Peninsula, and also give honor and recognition to the Chochenyo and Karkin Ohlone people, who are the original caretakers of the land in the Bay Area that we know and call affectionately the East Bay. A process of a land recognition is deeply important for many, many reasons of recognizing the fluidity and the spaces and time in which we come to, and then also as a practice of grounding us in some of our spirit and in our authenticity. So as you all know, that we are in an ongoing journey as it relates to the Great Revealer, also known as COVID-19 and the pandemic. I really want to start with the parallel, and what I will do in our short time today is kind of do a little parallel between COVID-19 and diversity and social justice. And I kind of want to utilize this moment that we're in to sort of examine the ways in which we show up. All right, so in this process, right, we do have COVID-19, but simultaneously, since early in the spring, there was a historical issue related to structural racism in our country that we have not fully come to acknowledge and discuss and dialogue about. But deeply, deeply powerful that as the pandemic was happening and as many communities were sheltering in place across the country, there was also a backdrop of the ongoing sort of violence and brutality for many communities of color, and specifically Black identified communities across the country. So data currently on COVID-19 really elevates and highlights what we have known in our capacities in the health sciences as health disparities. And so recognizing that infection rates and cases are almost 3 times higher in communities of color is deeply, deeply powerful. And not only from that place, there is also a lot of knowledge and information and research that's been done around the increase in anti-Asian racism and hate crimes for the API community across the country. Other disparities beyond health disparities for Black, Indigenous, and other people of color. We recognize the economic impact that has had disparities on different communities and individuals and families. particularly as we approach a holiday season, which is just a very, very powerful place to be in. And then finally, what is often very, very unseen are the different ways in which this current time has impacted mental health and wellness and well-being for folks, right? And so that could be the compounded effects of social isolation and distance that we've had from one another, and folks are already navigating perhaps other challenges. And so the complexities of those things, just wanting to give a word and light to that it is not in the abstract, and that these experiences are landing very squarely on the shoulders of the people that you all serve, that we collectively serve in our different various disciplines and our institutions, and also our families and those around us, our colleagues as well. So just want to give voice and recognition to that. Something that's deeply, deeply powerful for me, one of the pieces that really stood out when we talk about the numbers, and if you come from a numerical space and a science and a research lens and statistics and numbers land for you and it's powerful, another thing that is also sort of heart-centering is just recognizing the stories and the individuals behind the numbers. And so while I am from the Chicagoland area, both of my parents were born and raised in the segregated South in Mississippi. And when I came across this article highlighting that COVID had claimed the lives of 81 members of the Native American tribe in Mississippi, it deeply impacted me, thinking about those 81 individuals of culture, of story, of history, of language, and that will not be regained. And so when we look at the disparities, particularly for our Latinx, our Native communities, both in other regions, but also specifically in the Dene tribe within Arizona and New Mexico, and for Black communities and other communities of color, to recognize that beyond individuals, that there are stories and culture and legacies that are very lost. And so simultaneously as COVID was happening, there was also a reemergence of surrounding the movement for Black lives. And so I'm going to take us back in time just a little bit to 2013 and to recognize and to acknowledge the founders of Black Lives Matter, Patrisse Cullors, Alicia Garza, who is in the center of the photo, and Opal Tometi, who organized under the hashtag Black Lives Matter to raise awareness and to shed light on the murder of Trayvon Martin, who was a 17-year-old child who lost his life in Florida. And not only for him, but for many others across the country who were losing their lives both in visible and less visible ways, and really wanting to mobilize and organize to say that this level of violence in our communities is also a public health crisis as well. And so as COVID-19 became real and became online, every single month, individual, a Black identified person, lost their life in a very visible and violent way. And so we had the murders of George Floyd, Ahmaud Arbery, and Breonna Taylor, just to name a few. And there are many other names that will never get that same level of light and visibility, names that we know and names that we don't know. And so here again, the duality is the ways in which these themes intersect, right? The ongoing issues of structural racism in our country, but then also COVID-19, and that interplay is beyond just health disparities that affect communities differently, but it is layered in ideology and is layered in structures and systems of oppression as well. So I'm going to back it up just a little bit for you all because I might have already said some words, but again, I want to provide some foundations around diversity. So first part, the term diversity often gets conflated or just distilled down to just being race or ethnicity. But we know in truth that diversity involves and includes all of the variety of differences that people bring when we come together. And that could be our background beyond just culture, race, and ethnicity, ability status, religion, language, etc. We have so many social identities, the ways in which we approach and understand family, if we are caregivers for others, how we see and think and experience the world all around us. For a long time in the world, in the landscape of diversity and inclusion, there was an effort to provide evidence that diversity was not only a good thing to do, but it also made dollars and cents. And so you might oftentimes see sort of the elevation of the business case for diversity, being that there was a lot of research done to really provide some foundation to say that diversity mattered in the workplace in terms of creativity and efficiency and effectiveness. And so what research has shown is that diverse teams outperform and are more innovative than homogeneous groups. And I would say deeper beyond that, right, if we think about our institutions and our commitments, whether that's in healthcare or science or research and education, that we also want to show up in this mission, knowing that diversity, equity, and inclusion is part of our objectives and a part of our commitments in our work. Inclusion is another word, and if we think about these words all together as a bit of a formula, inclusion is best demonstrated through an organization's behaviors, actions, and policies that support its members and their ability to fully participate and engage. So sometimes, yes, diversity does get distilled to representation, but once we have that representation and we invite people to be in our community, whether it is in the academy, whether it is in the acceptance of admissions of our medical students, our residents, and other trainees, right? We want to make sure that they have the ability to fully participate, to fully contribute, and to actually share their gifts and their talents. And then thirdly, we're going to come to my favorite word, which is equity. So equity by definition is when two or more groups have parity or are on relatively equal standing. And oftentimes it is sort of used in concert with the term equality, but there is a difference. And so equality oftentimes attempts to distribute resources in the same manner across groups. So meaning what I do for one, I need to do for another, right? Whereas equity acknowledges that groups are actually positioned differently across our systems, right? So underneath the surface, what are the mechanisms, what are the pathways, what are the routes to be able to create that sense of access, and recognizing that that might be different from one individual to another, or one population or one sort of group to another, and being able to think about that more thoughtfully. A common graphic that I still use because I think it's really powerful is this image that sort of juxtaposes on the one side of your screen 3 individuals that all have a single box, and the objective is for them to be able to see and watch the game. So to be able to see over the fence and watch the game, right? And so I do think about this. If you all have 2 or more children in your life, I do not have children, but I do have one sister. And so when I was a young person, it wasn't her birthday and she got something like a gift or a present or a treat, and I didn't get one too, it would have started a whole lot of trouble, right? So equality comes from that spirit of like, what I do for one, I want to do for the other, right? But the image really kind of highlights and shows us that these individuals all have different levels of need, right? And so the distribution of the resource should be given in such a way that the outcome, their ability to participate, is actually what we're looking for to be the same. A foundation that is rooted in equity, and a very sort of example that leads into my next point, which is around targeted universalism, is the Americans with Disabilities Act and the installment of curb cuts in our built environment. And so for those that may not recognize that everywhere you go in many physical spaces, particularly newer spaces, the external curb will meet flushly with the ground, right? And in many spaces, there's this yellow placard. And so know that yellow placard isn't there to just give you traction on a rainy day, but in actuality is there for those who navigate the world needing a visible or an audible cue to let them know where they are positioned in public spaces and in places where there's traffic, right? And so, in fact, when they implemented curb cuts, they didn't go around cities and buildings and say, well, which streets are most widely utilized? Which parts of the building might need this the most? They implemented a universal strategy, universal policy. And they are so ingrained into everything around us that, in fact, now everyone uses the curb cut. Right? So even though it was designed for someone who maybe had a physical disability or another need, right? In truth, everyone uses the curb cut. So in our next image, we see someone on a skateboard about to go up on the curb cut, and then following them, you know, a person with a stroller, and probably a young child in that stroller going to use the curb cut. And so if you ever dragged a piece of luggage across the street, or a heavy object, or used a cart or anything like that, you probably use the curb cut. And so this universal strategy actually benefits everyone. And so this really comes from the theory of Professor John Powell, who is at the Haas Institute of Othering and Belonging at UC Berkeley. So what Professor Powell says is that, you know, targeted strategies can be used to achieve universal goals. And again, right, building on this perspective of equity, right, groups are situated differently. And what Professor Powell says is that when we address the needs of our most marginalized community members, everyone in fact benefits, right? So when we can create targeted initiatives, right, with the spirit of recognizing what is our outcome goal, if that is access, if that is care. And so within that, sort of kind of pulling these two pieces together, I think that it's really important that if we are going to create a change, whether it is in this moment of COVID-19 or other areas of health disparities, we have to be able to not just talk about diversity, equity, and inclusion, but we also need to be able to have more challenging conversations around race, racism, and specifically anti-Black racism. And so one of the most important pieces to recognize is that the social constructs of both gender and race are deeply embedded in our systems and the world around us. And by being a social construct means that sort of the roots and the foundations of the creation of the term race to separate people based on physical appearance, national origin, colorism, and language is not an accurate way to distinguish groups, right? So race doesn't hold true scientifically, and as many of you all know in the sciences. However, it deeply impacts people, and racism deeply impacts the ways in which people have access to health and other places of opportunity in their lives. And so altogether, right, in order to sort of be thinking about how do we address this current moment, I think that it is an invitation in our sociocultural climate to not just talk about social justice in places out there, but to actually turn within ourselves as individuals and actually members of our teams and our organizations to say, well, then how do these themes show up? How does structural oppression show up in my work? How does it show up in my organization? And what opportunities do I have to address that? And so how we can do that is to further our knowledge on diversity, equity, and inclusion, to engage in dialogues about race, racism, and structural racism, again, to be able to come fully into those conversations, and to examine the ways that structural racism and other forms of oppression show up in our institutions and our organizations. Perhaps that is across healthcare, education, research, and our workforce, and to pivot our initiatives towards equity also. And so finally, I'm going to invite for our participants, all 29 of y'all, to get ready to navigate over to the chat. Because I want for you all to sort of utilize this last example just to highlight and just to bring home a point. So the question that I have for you all is, perhaps what were you all doing? Thank you. What were you all doing when you knew that the COVID-19 pandemic was real? What actions did you take to support others? And go ahead and reflect in the chat. Some of these come from my own experience. Perhaps you were hunting around your house or your office, looking for extra PPE, maybe sharing that PPE or that mask with somebody who didn't have one. Maybe you were going through your conference bags. I know, right? In healthcare, we go to a lot of conferences, looking for all of that swag, hand sanitizer that folks gave out. Maybe you took up sewing and you made homemade masks by watching YouTube videos. Perhaps as someone who is rooted in healthcare, you had more knowledge and more information, and so you were calling friends and family members. Maybe they felt like you were nagging them to emphasize the importance of that. Maybe you volunteered, right? Yourself, your kids, your family members for community service. Maybe you gave, right? So if you can go ahead and acknowledge in the chat, what did you all do? What did you all do? Any of these things? What did you do when you knew that the pandemic was real? And maybe you're with me reflecting internally. So perhaps you can anchor into that. And so as health practitioners, you likely have a little bit more information or insight, maybe around viruses and etiology, etc. But right, maybe you were looking for those supplies that were all out in the grocery stores. Absolutely. But the point that I want to make is that you likely did not know the gravity of where we would be, here 6 months later, 8 months later. And so you did all of those things with love. And it is the same energy and the same insight that we need to show up to our work around diversity, equity, and inclusion. We may not always feel like we know the right thing to say or have all the knowledge or have all the words organized. Maybe we can't quite see the ways that structural oppression operates in our environments, but as we are in conversations with others and we watch and we learn more, we begin to see and hear things a little bit differently. And so it is the opportunity, again, to show up not because you know everything about it, but to show up in the spirit of love. And so with that, I'm going to close out and ask that you all save questions for later, and we'll do some Q&A at the end. So here I will turn it back over to Dr. Samplaski to introduce our next speaker. Thank you so much.
Thank you so much, Dr. Hill. I just wanted to take a pause and read some of the responses that were in the chat box. In response to what did you do when you found out about that COVID was going down? And I mean, some of these are really sweet. Bought food, learned how to return safely home, learned about being in the hospital, binged on Twitter, learned as much as I could about COVID, spoke to family and friends about the importance of wearing masks, tried to reassure patients. So I think people had a variety of different responses. I tried to find paper towels. It's an interesting dialogue, and I just want to thank you for your wonderful presentation. Our next presenter is Dr. Tolulope Bakare. She's originally from the Houston area. She got her MD at Penn. She did her residency at the University of Arkansas and then went on to do a fellowship at the University of Illinois. In 2017, she joined the faculty at UT Southwestern and is now the male infertility physician in that department. She's going to shift gears to more of a clinical, patient-centered experience. And Tolu, I hand the stage to you.
All right. Thank you, Dr. Samplaski. So my name is Tolulope Bakare. I'm an assistant professor at UT Southwestern, and I'm really excited about the opportunity to present and give this talk that is something that's near and dear to my heart today. When I first started my practice, one of the questions I had was, as a Black woman, how do I ensure that I have a practice that caters to not only all groups, but how do I ensure that, minorities and people that look like me had adequate care, especially fertility care. And, that's kind of it's been an evolving process for me. And I think, and I'm excited about the opportunity to share some of the things that the insights that I've gained along the way. So disclaimer, I have nothing to disclose. I want to start with this ASRM I want to start with the ASRM declaration that characterizes creation of family as a basic human right. If this is true, then building a multicultural practice is something that should be of utmost importance to us all. So while there may be a debate over the percent of male factor contribution to infertility, it may be about half of male factor in about half of couples that are infertile. Unfortunately, not all men are getting evaluated. There's recent published data from the National Survey of Family Growth that found that in the evaluation of infertile couples, about 18 to 27% of the time, the male was never actually evaluated. One of the many reasons this holds significance is that many argue for fertility as a metric of male health, as we know. Infertility can be associated with increased risk of testicular and prostate cancer. And about 1 to 6% of men referred for infertility evaluation, they can be ultimately diagnosed with serious medical pathology, including genetic abnormalities, hormone abnormalities, malignancies at the time of their evaluation. These pathologies may not be picked up on semen analysis, as we know, and while labs have an extremely large role in management of these patients, and they can't replace a good history and physical exam. So while I put on there that 18 to 27% of male out there do not undergo evaluation, I don't want to imply that these men are not appropriately referred. It's possible they're referred and just not following up when referred. Okay, so why is this important? It is important for us to evaluate these patients because it allows us to provide adequate care. More specifically, in African American patients, we know there's an increased risk of advanced prostate cancer at presentation, and the early detection and management of these patients is key for them. A report in 2009 commissioned by the Joint Center of Economic and Political Studies estimated that about 220 that it was an excess healthcare expenditure of about $229 billion for minority patients. And this expenses could include treatment of advanced diseases, for a need for more critical care when they present later with those diseases. So, you know, this tells us that not only do health disparities not only affect individual populations like minorities, but they're also costly and really burdensome to our entire U.S. healthcare system. So again, we can also potentially improve the cost of fertility care for patients when we actually provide care. As we know, most people that do male infertility, varicocelectomy is a procedure that, if done in a patient that's oligospermic with a grade 3 varicocele, may actually result in improvement of their seminal parameters and potentially improve cost for fertility treatment for them. Also, this may alleviate stressors by helping some of these patients father their own biological children. Evaluating these patients can also result in improving marital, cultural, family stressors. There's a lot of cultures where there's a significant amount of pressure on the couple when they're trying to conceive, and getting evaluated and getting the proper treatment that they need may actually help with this. It also helps us physicians having exposure to people that are different from us, even if it's in our clinic life or in our work life. Certainly enhances our lives and enhances our understanding of other cultures. So moving on to access to care. As we know, the true prevalence of male infertilities is unknown. It is challenging to assess disparities, specifically in male reproductive care, as a result of this. However, there is some data from the female side of things, and looking at the female data, it suggests that when comparing Black and white women, Black women have experienced have increasing infertility compared to their white counterparts. Now, this certainly could be increase in reporting because of more public knowledge of infertility, but we don't know that for sure. There's also evidence that Black women tend to have infertility for longer periods of time before seeking care. Again, the delay in their treatment could be due to different things, including income, education characteristics, knowledge of their healthcare options, and of course, cultural differences. So while we don't have the same data in men, we really don't know, it is not unreasonable to make a similar assumption for minority men. And we'll discuss that a little bit. So in 2016, Meta in Fertility and Sterility described some limitations and barriers that are in access to care for male reproduction. Some of the barriers that they described are epidemiologic, geographic, knowledge-based, financial, socioeconomic, and of course, health policies from our government. So diving in a little bit further, they describe those barriers in this table. We're certainly all aware of the limitations regarding the number of male infertility specialists in the country. I think we're all familiar with that. However, other factors, including limitations in the knowledge of the provider, of the patients themselves. For example, a primary care provider treating a patient with that's azoospermic, oligospermic with testosterone to boost their sperm count, which horrifies us, but it's still being done. And so these are true barriers in caring appropriately for those patients. There are also economic factors due to lack of proper insurance coverage, even limits in coverage in mandated states, and even when there is coverage, patients may not be able to afford the rest of the payments or whatnot needed for their fertility care. And then it's very important that male infertility is recognized as a public health issue, as this will likely enhance coverage with insurance companies and other methods as well to be able to give our fertility patients the care they need. So are there solutions for us? For the male reproductive urologist, we are in a not so great position of dealing with issues with fertility access to all patients. And then we compound that with the additional issues of access for minority patients. Even though a lot of these issues are complex and systematic, I think there are things that we can do as individuals and providers that we can to improve some of these things. And those are some of the things that we'll touch base on today. So one of the things that we can do is to improve our organization. The AUA Census data shows that there are only 2% of reportedly practicing urologists in the country are African American. Furthermore, 3.4% of practicing urologists, according to the AUA 2019 census data, are infertility specialists. Now, looking at those two numbers of 2% African American of urologists and this number of 3.4% of male infertility specialists, I think it's pretty safe to make the assumption that there's probably a really small number of male reproductive specialists that are African American. We don't have that data, but I think it's fair to make the assumption that that is the case at this point. So this is a problem because there is existing and emerging evidence, that patients tend to be more responsive to physicians who will look like them, and there's that's a reality that we live in, and we'll touch base on this a little bit more later. So you may be wondering to yourself, well, I am not a minority, so what can I do? I think even if you're not a minority physician, I think there are things that you can do that can enhance and improve disparities in our infertility world as well. So one of the things that we need to recognize is our own personal biases. Physicians may unintentionally incorporate our own racial biases into our patient interactions. This can affect the interpretation of data, interpretation of their symptoms. It can affect the decisions we make in taking care of our patients. Our biases may also skew our ability to understand the cultural differences that exist and the patient's expectation for their visit. Now, one of my favorite studies that looked at this is a study that was done on implicit bias. It was a large study that was published in the Journal of Healthcare for the Poor and Underserved using the race IAT test. And I'm not sure if everyone is familiar with the IAT test, but it's a validated timed cognitive test that measures the relative association strength between two pairs of concepts. So concepts like race and then evaluation like good or bad. So race and then good or bad. It was developed at Harvard. And the researchers for this particular study hypothesized that using the race IAT test, they would note that people, and medical doctors specifically, had implicit racial preferences, and that those implicit racial preferences will be stronger than their explicit racial preferences. That means that they predicted that amongst medical doctors, our perceived biases will be actually less than our actual biases. And you can actually do this test online yourself. What they did in this study was they looked at people that took the test over about a 28-month period. So they didn't recruit patients. They basically, people find out about the test online by talking to friends, family, or media coverage. I personally heard about the tests from a podcast that I listened to, and I took the test myself. Test takers are basically asked to quickly recognize facial images and some words that appear on their computer screens. So what they do is they are asked to recognize Black faces, and either categorize them as Black or white, and then white faces, put them in the white or Black boxes. And then they also put associated Black and good and white and bad. And basically they would flash a word like kind, and you were to put kind under good, which would be associated with Black as well in that test, or evil with bad, which would be associated with white. And then they flip it, so they make good, they have good words with white faces and bad words with Black faces. And so basically what they were doing was to what they were doing was to look at the difference in the response time between the two conditions, and the people taking it. So how quickly did you assign a good word to a white face, or how quickly did you assign a bad word to a Black face? So when they did the study, they basically had a couple of findings, and this is basically the correct characteristics of the people that took the study. They had over 300,000 test takers in a 28-month period, and over 2,500 of them were medical doctors. They identified medical doctors through self-reporting, and the racial breakdown of the medical doctors were 66% were Caucasian, 8% were African American, 11% Asian, and 5% of them were Hispanic. The scoring of the biases was -2 to +2. So +2 indicated a preference for white Americans, -2 represented a preference for Black Americans, 0 being neutral. They look at the mean scores for the participants and use the Cohen-D score to determine the effect size. Amongst all physicians, there was a 0.3 mean, which indicated a slight preference for white Americans over Black Americans. And the interesting part is when you actually look at their reported biases, it was lower than the actual biases. So it shows that what we think what we think about biases is actually not, may not be reality. Looking further, when we break it down further amongst medical doctors, white physicians had a mean of about 0.4, which indicated a preference again for white Americans over Black Americans. When you look at African Americans, their mean was 0.05, which was a very slight preference for white Americans, but significantly less compared to the white physicians. And the effect was very small for the African Americans when you compare it with the effect for white Americans. Interestingly, Asian Americans and Hispanic Americans had the same biases and preference for white Americans over Black Americans. So this initial chart looks at the breakdown of race and gender, but let's take a deeper look at the MDs in this picture. This continues to show the consistent preference of white Americans for white MDs over white Americans. Specifically, this persistence preference for white Americans and the white male medical doctors, which is a 0.49 mean. And interestingly, their perception of their biases was actually quite the same as their actual biases when they took the test. I just want to give a little shout out to African American women because they were pretty neutral in this test, even though their biases was they thought they would have a preference for black Americans, but they actually were pretty neutral when they took the test, and it turned out pretty even for the African American people, and those effects of the data in the male was pretty small in African American and zero in African American women, and still pretty significant in the Caucasian group. Okay, so what does this tell us? Physicians are humans too. We have biases and we need to recognize them. And I think recognizing them and course correcting is very important for us as physicians to be able to take care of patients. You can actually take this test on the website if you would like. I have the website on there, and you just go on there and you choose the race IAT, and you can see how well you do. My colleague and I recently took the test. He's a white man, and I'm an African American woman, and I won't tell you the test results, but I think you can probably imagine what the test results were. So in the interest of time, I won't dive much into the data here, but the other studies have shown basically that the reported difference in participation of visits for African American patients were less during the visits. There's a study published in JAMA, which basically evaluated participation styles during the visit between a patient and physicians, and African Americans rated their visits as less participatory. They felt like they were being talked to and not necessarily making a decision together about their care, which makes for an unsatisfactory care for most of these patients. And then, there's studies out there to show also that patients tend to have more satisfaction in their visit when they feel like they're treated like a human being. So I think the summary of some of this part is treat people like human beings. And I think for the most part, I think we can make a difference in doing that. Another quick study that I was going to touch base on, there are many of these talking about general differences in perception of care, but one of these interesting ones done by Johnson in 2004 documented physician behavior during real world clinical interactions. And they found that physicians actually spent less time with African American patients. They were more verbally dominant with these patients, and they had a less positive effect overall on African American patients compared to their white counterparts. These experiences can completely turn off patients from seeking care and cause them to avoid the healthcare system as a whole, which unfortunately, if they avoid healthcare system, can increase the cost of healthcare from advanced diseases and things like that before patients show up for care. So these are some of the personal things that I've heard in my practice when I see African American patients that have come to me, especially if they've seen someone else prior to seeing me. Things like they thought I couldn't afford it, so they didn't discuss all my options with me. I felt like I was being lied to. I felt like I was being dismissed. I didn't trust him because I don't feel like he did a proper workup, and I think he was just trying to get me, or things like that. And so, health professional education programs may benefit from increasing provider self-awareness of implicit attitudes about race, and how these attitudes may actually affect our clinical care as clinicians. The key really is to recognize and be able to correct these biases we have. So here are some personal ideas that I've done in my practice. And while there's no strong data around this, because there's really no data out there about how to build a multicultural practice in male infertility, some of the things that I've done and have really significantly impacted my practice is making an effort to do outreach with minority physicians. So like the REIs, the family medicine doctors, the OBGYNs, like those are the people that are the front lines of seeing these patients that end up referring them to us. So making special effort to reach out to them may show them that you care about their patient population and you're interested in taking care of them, and that may help improve their referrals that come your way. Certainly engaging patients in their care is paramount. I mean, that's very important, and a lot of people appreciate that. Developing a standard for discussion with all fertility patients, even though we have, AUA recommendations and things like that. I think making sure that you have this similar, I recognize that patients are different and you may alter things a little bit, but making sure that if you're seeing a nasospermic patient, you talk about IVF, you talk about all those things and not skip things because you make an assumption from your own implicit biases that they cannot afford it. And of course, as an organization, we need to continue to champion legislation that promotes equal access and coverage for fertility care. In summary, improving diversity in urology and male infertility may help improve evaluation and care of minority patients. We should certainly continue to strive to eliminate the barriers that we previously discussed. Recognize your own biases. We all have them, no matter how unbiased you think you are. We all have them. Outreach to physicians that are the first line to these patients is key in order to recruit this patients. And of course, the more these physicians refer to you and they see that their patients are happy and pleased and that they're being taken care of and not having those feelings of not being cared for, that'll inevitably increase those patients in your practice as well. Now, obviously, there's a lot of systematic issues that that is, a little bit beyond us as individuals sometimes, but hopefully continuing to champion legislation that can affect that as an organization are things that is something that will help us in the future as well. So those are my references, and these are my references, and thank you.
Thank you very much. We'll now open the floor to questions for our panelists. Please send in your questions through the question chat box located in the gray toolbar to the right or bottom of your screen. Dr. Samplaski will moderate this session.
So I'd like to thank both Drs. Hill and Bakare for these wonderful lectures that you've taken the time to put together. When I was thinking about these discussions, I think sometimes bringing up some of these topics can feel a little uncomfortable. And so I would be curious to know, and I sort of thought, how could I integrate this into my practice? If you have any real life tips, and if we should be the one with patients to sort of initiate some of these conversations. I would say, like, for example, sometimes I'll ask patients, do you need a physician that speaks Spanish? Do you have a gender preference? Do you think we as physicians should be the one to sort of initiate and try and make the connections for these patients if they have cultural needs?
I think so, 100%. I am not shy about asking my patients that. Now, if they tell me that, it doesn't matter to them, that's fine. But I certainly, if I have Spanish-speaking patients and I see them first and they want to see an REI, I will ask them, do you prefer Spanish-speaking, REI to go see, or what are your preferences? Because at the end of the day, I think there's a strong association with your feelings about your physician and your outcome, right? So whether IVF is going to work for them or not, or whether this is going to work for them or not, as long as they feel confident in the person they're seeing, I think then whatever the outcome is, they're still satisfied with their care, if that makes sense. And so I am not shy at all about asking patients about if they prefer. They know they're Hispanic, they know they're Black, so you're not reminding them of it. You're not reminding them of it by asking that. So I don't mind asking, and I mean, I've had patients tell me that they came to see me because I'm an African American physician, and they felt that they would be in better hands. So in that situation, I have no problem telling them about that.
If I could just add just a couple pieces to this point of sort of navigating what is, I think, a very human emotion. I'm a psychologist, so I'm just going to dig into this, right? Which is that the what feels like discomfort. It is actually not discomfort. We just name it that. It's just a little bit of activation. If we were to ask you all to introduce yourselves one by one on this panel, when it's your turn, you're probably going to get a little activated, right? But you don't name it discomfort. You don't name it a challenge, and you don't name it hard. So as a psychologist, I'm really kind of trying to be on this mission of like, we need to sort of pivot away from calling DEI hard. I'm not going to say that it's always the most comfortable thing to do, to either address microaggressions or acknowledge moments when we may have shown up a little bit less than our ideal selves, or we might be able to be have learned that we committed a microaggression or had bias, or as an educator and as a provider. But there were things that you all were collectively trained on that at one point were very, very, very hard, right? And as you went through your skill set, you created a little bit more mastery, right? So in this work of reproductive science and working with a lot of urologists, I said, what is this random clinical thing that you all do? And Dr. Seema Porton told me that y'all have to be able to navigate catheters. I was like, okay, that's random. I would have never known that. But the point of the matter is that if that was something that your patient needed, you wouldn't call, expert, Dr. Jones every time that a patient needed this one thing, right? Even if you missed the lecture in school and, were absent for that month where they were teaching this clinical skill, you would still ethically go back and get it, right? And you wouldn't leverage all of that work onto a few of your colleagues because they were better at it, right? And I think about that just in the small sense. Partly it's to be able to shift the emotion around it and then elevate that up to the next highest thing, right? If there's something critical, or if there is a medical emergency, or if there is information around any sort of health concerns, right? You ethically still have to deliver that message, even though it may feel challenging and it may feel difficult. And so it's these skills that I really encourage people to draw upon as we're thinking about diversity, equity, and inclusion, that we can't just move away from it because it's uncomfortable, and we can't just give it to our colleagues or our team members who we think are better at it than us.
And Tolu, and actually to both presenters, I think from a real world perspective, as we're seeing, because I think there's a lot of clinicians on this chat, what are some real world ways that we can connect with our patients on these issues? Is it just being sort of blunt? Is it sort of like how can we let patients know like we are interested in sort of meeting this need on a day-to-day basis?
So I think one of the things that I've found that works for me is I guess being also you have to know your crowd, but you also have to you kind of have to be I guess emotionally and astute in a way where you kind of can walk in the room, and when you have a perception of like concern from a patient, right? They see you and you can assess from the moment you meet them that they're a little skeptical. And I've encountered that in my life. And I've had patients that have seen other people and they've spent a ton of money and they don't trust me. Like I've had people that basically the REI basically convinced them to come see me, and they didn't want to because they've had so many other they're very skeptic. They're of the whole medical system, and so they have a lot of. So those patients, when I detect that, I know it's time for me to take a step back and just you know, really make sure they understand that I'm there for them. You know, those are the patients that I say, you know, there are times also that, you know, when I see, so I'm a Nigerian woman, right? Sometimes I will see Nigerian patients, and men that are come from very, very cultural backgrounds, like Nigerian men, have this, you know, it's a huge ego hit for them to be diagnosed with male infertility. So I literally go through this, you know, this is not your fault conversation. And I'm not afraid to go there with them, because I know, I guess also being from that culture, I understand the stigma that comes with it, and I understand the stressors that come with it. So I really make sure I let them know. So I don't avoid it. I don't pretend like it's not there. I address it face on, and I say, listen, I know this is hard. I know this is going to be rough for you. I know family is going to be this. I know this is going to be that. But I want to let you know that this is not your fault. You didn't ask for this. You didn't do anything to deserve this. This does not make you any less of a man. And I basically have like a counseling session with them as well during that visit. But it's because I know that's what they need in that moment. And so you kind of have to be able to read the room a little bit to be able to counsel some of these patients, to let them know that you are there for them. But I also don't think it's that hard to read the room. I think some of these patients will let you know that they need that reassurance from you. It's on you to recognize when they give you that signal. And they will give you that signal. You just have to recognize it. So yeah, I would say, you know, I would say you see it in clinic, and you're able to recognize it and just tackle it head on, and not avoid it or not scheme around it because you're afraid of offending anyone.
Dr. Hill, I'd be curious to hear your thoughts as well.
Yeah, so one of my favorite frameworks is cultural humility. So if you haven't come across it, I encourage you to look it up. Developed by Drs. Melanie Turvalon and Dr. Jen Mary Garcia. And the framework and the foundation is sort of rooted in three core parts, but the first two I think are really helpful for how we show up, right? And so the first part is critical self-reflection and lifelong learning, right? So we are the experts on our own lived experience, and we need to examine and understand who we are, where we come from, with the level of authenticity and agency, and right, being able to show up and say, this is who I am, and then simultaneously allowing other people to do the same. So in our patient-provider relationships, particularly in disciplines of medicine and other specialties, we are also trained and taught to sort of do a lot of distillation of knowledge and information, of making decision trees and other sort of themes. So we are sort of conditioned and trained to do a little bit of assumptive work, right? And engaging in those projections. And it can be helpful in science when we're doing some reasoning, but it may not always be the helpful default when we're engaging with people. And so to show up and say, and to allow for the other person simultaneously to be the expert on who they are, what their needs are, where they come from, etc. And that practice of humility is deeply, deeply powerful, to not show up in our assumptions, but to show up in that listening mode. And the second part of the framework is to address power differentials. So as providers, right, you are holders of great power. And in these relationships, even though we may have shown up and said, I'm wearing my partnership hat, and I'm here to help you and to support you and serve you and cheer you on, and whatever the case may be, that dynamic and that privilege is always going to be inherently with you in your status as a physician, right? All of the extra letters behind your name, or just the environment in which people are coming into. And so we have to be conscious of that power, conscious of our privilege in those ways, and really seek to identify opportunities to be in collaboration, right? To create those collaborative plans and to partner and sort of seek out that information. So it is, if the patient doesn't ask the question, it doesn't mean that they don't have questions, right? We know this already, right? They don't ask questions because they are worried about taking up too much of your time, or they don't want to sound like they are uninformed, or perhaps they don't necessarily have the words or the knowledge to be able to ask a question, or it might feel embarrassing, et cetera, especially in the work that y'all do. So it is an opportunity to sort of to move forward and to sort of see the unseen, to name the unnamed. And a lot of that is sort of in these structures of equity and power.
Wonderful. Well, we are out of time for today, but this has been just a wonderful session tackling some very non-traditional for reproductive medicine topics, but it's great to get the conversation started. I'd like to thank both of you for all of the time, because I know, we've all done the behind the scenes work. There's been a lot of time and effort put into this. Thank you for all that you've done.
Thank you for
having us.
You will receive a survey by email after this session. Your feedback helps us give you the most relevant content, and your input is appreciated. This session was recorded and will be available in the near future. Please watch your email for notification about future webinars. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.